Hi, this is part 4 of talking about the phases of a COVID infection. Last time we talked about these distinct categories that create cryptic lineages, where you have a viral rebound infection or persistent infection, a chronic infection. So these can happen over a long period of time. We're going to be focusing today on Paxlovid rebound, which is a form of viral rebound, but I'd actually classify it as a false rebound. I'll cover that in a moment. But to reiterate, a viral rebound is when you have an initial infection, you are infectious to others, you don't fully clear the virus, but you get below the test positivity level. So if it was a rapid test, you go from positive to negative, and then the viral load would increase once more because you wouldn't fully clear it. And then you'd become infectious once more, so you'd go positive once more. But this would all be the same infection. This isn't a new infection that you're getting. This is the same one. And then you'd slowly clear it again, and then you'd hopefully become negative. But then this can just cycle on and off for a long period of time if you don't ever fully clear it, because it's found a reservoir to host itself within your body. So this can become a cryptic lineage in that way. But in a normal acute infection, this is also something that can occur with you ultimately clearing the virus. So first, what is Paxlovid? Paxlovid is an antiviral medication. What an antiviral medication does is it prevents or inhibits viral replication while it's in your body. So that's what an antiviral is. It works against the virus, and this is the official name. So Paxlovid is actually a combination medication of two different components. One is nirmatrelvir, and the other one is ritonavir. So these two things work in tandem to help fight the virus. As of right now, Paxlovid must be started within 5 days of symptom onset. So once your symptoms start, you have 5 days before it is too late, and doctors will not prescribe you the medication. This is based off of way back in like the early 2020, 2021, even early 2022 data. Now, since I've shown you like it's offset, we've right shifted. So now it's taking for the rapid tests about 3 to 6 days to first test positive. So we're now, oftentimes people are going to be sick for a while, not recognize it's COVID, then see it's COVID, and then it's going to be too late to be prescribed Paxlovid, which is a problem. And then moving over to the Paxlovid rebound section of this. So recall in part 2, I talked about the cycle threshold value. So this is a test we can do via PCR. So what they did here in this study is, and a quick overview, let's do that first. So as a refresher, the cycle threshold value is the number of culture cycles of COVID. So you're taking a swab of COVID from the person, you're culturing it. So you're letting it grow to a certain population level. And then once it hits that population level, you're recording the number of times that you had to repeat this culturing process. So if you have higher viral loads, it's going to take you a lower number of cycles to get to that population level. So that means you're sicker. If it takes more cycles, that means you're going to have less initial virus that you're starting with, that you're culturing over and over again, which means you're going to be less sick. So now that we have a reference for that, so this is a person that started Paxlovid. So they tested positive on COVID, and then day one they started Paxlovid. So the Paxlovid, the antiviral medication, is going to be inhibiting the COVID viral replication, which is going to start decreasing the values of COVID. The viral load's going down, so the cycle threshold value is going up. And as you'll see here on these rapid tests, it's positive, strong positive, and then it's getting lighter and lighter, and very faint in 6 and 7, so almost negative. So this is why when you're taking Paxlovid, you should not be wasting your tests on it, because the tests are just going to show you, hey, the antiviral medication is working. You already know it's going to work. It's an antiviral medication. So you're going to think falsely, oh, I'm cleared the virus. But if you test within 24 to 48 hours later, so right here, they skipped day 8 after they finished the Paxlovid, and then the very next day, they were strong positive again. So the inhibition of the viral replication was ceased. The virus was allowed to continue replicating within their body, and they instantly increased in viral load once more. So that increased, and they slowly decreased over time. So they got better. But this is essentially showing you what a Paxlovid rebound is. And I think it is important to note here that it took 18 days for this person to fully clear the virus, even with an antiviral medication. So the question then becomes, how often of an occurrence is this when you're on Paxlovid? So about 1 in 5 experience rebound of COVID after the antiviral drug. Now, recall, we are going to have natural cases of rebound infection by just having the COVID virus. But then when you're taking the antiviral medication, you're getting what I'm going to deem a false rebound, because essentially all you're showing is like, yes, the antiviral medication is working. When you stop the antiviral medication, it is no longer doing the antiviral work. So you're just showing like, hey, look, it works for this period of time, but it's actually not a sufficient enough dose. It's not a long enough dose to last for the duration of your infection to bring it down and keep it down. So I think the important points here are, one, that the antiviral medication reduces but does not eliminate viral production of COVID while taking it. People think that essentially the Trojan horse effect is happening. They've shown that that COVID can actually inhabit T cells within our body and do viral replication within those. So they think that it's sort of camping out in these cells, and then it's being eliminated, prevented from replication in other cells. And then once the antiviral medication stops, it continues its replication in those T cells and then continues elsewhere. So it's able to harbor out and sort of wait out the antiviral medication to continue its work. And again, the rebound only occurs because you brought the viral load down artificially through an intervention, and then the intervention was of insufficient duration. It wasn't long enough. And like, importantly, if one did not take Paxlovid, their infection would likely be the same duration, just at higher viral loads throughout the course of the infection. So you'd feel sick for longer, you'd be sick for longer, and you'd be more infectious to others, because when you're on this and you're reducing the viral load, you're less infectious to others. You might not be non-infectious ever, but you're going to bring that down and be less likely to infect those around you. And again, a negative rapid test while on Paxlovid means that the viral load is below the test detection threshold, not that the virus is not present anymore, so you can still infect other people. And ultimately, what this means is that Paxlovid is still good, because while you're on it, you're less infectious to others, you're producing less total virus, so there's less body damage to you. And then you're also likely below symptomatic levels, so you actually feel better too. So some doctors have gone and said, oh, because you're having this rebound, I'm not going to prescribe it to you. This is a very common thing with this medication. I think this is very short-sighted. I don't think they're interpreting the data correctly. I think that they should all be advocating for Paxlovid usage. And then I've said a few times now that the duration of treatment is not long enough. So with our 5-day course of a treatment, there's been modeling software. So essentially, they've looked at a couple different things. They've looked at when you start the treatment. So if you start Paxlovid for this 5-day course early on, so on day 2, you have an 80% chance of rebound. But when you start it later, like on day 5, you have about a 10 to 15% chance of rebound. So when you start that course is important, because you want to try and time it with the peak duration of the viral load to blunt that down when COVID is doing its work. And here's all the modeling here showing these different plots right here. Other studies have done some computational modeling to look at the course duration treatment with Paxlovid on COVID-infected individuals. And it shows, so we have our typical 5-day treatment all the way up to a 10-day treatment. So even if we went to 6 days, there's a dramatic reduction in COVID rebound. And then once you get up to 7, 8, and 10 days, these 3 boxes over here, regardless of when you start the Paxlovid with a longer treatment course, you'd virtually have 0 rebound, because the treatment is long enough for the infection. The treatment just has never been long enough for our COVID infections on Paxlovid, which is just sort of unfortunate. So now that I've talked about everything that can happen in the acute phase of COVID infection when the infection is actually happening, let's talk about the post-acute infection phase. So there's essentially four different parts. So you have the post-acute infection period, which is typically considered like 4 to 6 months after you test negative, where you still have these body effects from the infection. Then we have post COVID complications, which typically can last anywhere for up to a year post infection, maybe for life. But this is what it's typically considered is about a year. We have long COVID. So this is 3 or more months post infection for an unknown full duration of time. It could be for life, could be a couple of years. We don't know a lot about long COVID just yet. And then we have viral persistence. So this is the infection was never fully cleared. You have viral pockets within you that can create chronic infection. So you could just have like high levels of the virus still, or it can be in pockets like your intestines, your eyes, your lungs, the nasal epithelia, and your salivary glands. These are different places COVID can camp out. But these are essentially the two main categories that I'm interested in. I'm going to cover all of this shortly, but post-COVID complications and long COVID are essentially grouped under infection-associated chronic conditions. This is a new term that was developed by a working group because not just COVID has long-term chronic conditions, you can have other things from other viruses. I actually have a long-term chronic condition that is from a virus called norovirus. So I contracted norovirus, and within 3 months from that, I ended up developing a gluten sensitivity where I'm no longer able to eat gluten because of the virus. Very interesting stuff. I've looked into a lot of research in this, but it's just one of the things that can happen. So that's a type of chronic condition that can occur after a viral infection. So first, let's talk about what I'd consider the post-acute infection period. So this is going to happen with every single COVID infection, essentially. So for the post-acute infection period, this is going to be every COVID infection will result in a lot of these regardless of infection severity or duration of symptoms and illness. So it doesn't really matter how long it is. Each infection will cause these things. So first, you're going to have thickening and lengthening of the microvilli in your nose. This can make it more difficult to smell, and it also will decrease the ability of the nose to clear debris in the long term. It's unclear if these are permanent changes or if they will heal over time through cellular shedding. It's not certain right now, but this is something that happens through viral entry. Basically, these microvilli are like windshield wipers in your nose that are constantly moving back and forth that help clear things. They get very long. They become like tentacles instead of fingers. Through COVID, it aids in the spread of COVID within your body. But this is something that occurs. There are going to be spike protein fragments that will remain as cellular debris within different organs like your brain, which cannot effectively clear them. So this is going to be a cumulative damage from every single COVID infection. And then again, due to the spike protein's ability to cross the blood-brain barrier, which is not common to viruses. Not a lot of viruses can actually cross the blood-brain barrier because it's supposed to be a net to sort of block a lot of stuff from happening. But COVID's spike protein is able to cross this, and it will, once it's in the brain, it can disrupt neural pathways and metabolic pathways. It sort of has two different sets of things it does. So with the neural pathways, it can actually fuse neurons together, which will cease their function, disrupt their function, creating like lower levels of signaling in them. And then it can like reshape different pathways in your brain because of this loss, making signaling less efficient and generate brain fog. It can also decrease metabolic output of your brain, which they found, which is really interesting, which will also contribute to brain fog because you're not going to be thinking as efficiently as you did in the past. There are going to be changes to your blood. Within this time period, it's going to become more viscous, so it's going to be sludgy. So it's going to be harder to move the blood around. And then you're going to have fibrous microclots from every single infection. And then these can create large chained blood clots, which can then create things like strokes, heart attacks within your body. They won't always create these long chains, but they will at least create small chains of fibrous microclots, and these are really hard for the body to break down. And this will impair your ability to exercise and again increases the risk for stroke and heart attack. The inner lining of your blood vessels will become damaged, which is going to also promote clot formation. So when you have these damaged inner walls where things can get stuck in the little cracks, and coupled with the fibrous microclots, this is primed to cause issues. You're going to have an impaired immune response for a minimum of about 6 months due to T cell exhaustion and hijacking of immune cells for viral replication. In men, you're going to have impaired semen production for about 6 months, which is going to result in increased infertility post-infection. And then this is particularly if you're pregnant. So if you're pregnant within the second or third trimester, there is a pretty high risk of complications, particularly from these fibrous blood clots. So they can create massive blockages, restricting blood flow and nutrients to the fetus within the placenta. It's actually termed SARS-CoV-2 placentitis, brand new phrase for this thing that happens. And you also have a higher risk of things like stillbirth, neurologic defects in the child, among other things. So this is something that can happen in the post-acute infection period specific to pregnant women. And then let's move into post-COVID complications. So a lot of times there's a lot of terms that are used interchangeably with long COVID. One is post-COVID complications. Another one is PASC, post-acute sequela of COVID. So I'm going to be using post-COVID complications as sort of a discrete form of impacts that can happen from a COVID infection outside of long COVID. They could be also classified as long COVID, but I'm going to use this as discrete events after the illness. And then I'm going to be grouping long COVID and PASC together into one category. So this is how I think it should be split, but both of these are going to exist under infection-associated chronic conditions. So first, let's start with post-COVID complications. So again, I'm calling this a discrete event after your illness. So these are complications that would arise because of a COVID infection. They may or may not also be classified as long COVID. It really depends on the definition used, but approximately 1 in 5 adults, as of 2022, the CDC released this. Approximately 1 in 5 adults ages 18 and older have a health condition that might be related to their previous COVID-19 infection. This can include the gamut from neurologic and mental health conditions to cardiovascular, kidney conditions, respiratory conditions, musculoskeletal conditions, and blood clot and vascular issues. So that number has certainly gone higher since then, and I'll show you why in a second. But things that I would classify in this type of category would be new heart issues, heart attack or stroke, anosmia, which is loss of smell, ageusia, loss of taste, vision issues, so worsening quality in your vision or loss of your eye from the COVID infection, because remember, COVID can directly infect your eye. That's an infection route for COVID. And then again, pregnancy issues, so the SARS-CoV-2 placentitis that results in stillbirth, neurodevelopmental delays, and etc. So this would be a complication for the child that was born from a mother with a COVID infection in predominantly the third trimester, but also these types of things can happen in the second, not as common in the first. And then there is kidney problems that can occur. New onset diabetes. This one can also be more strongly grouped in the long COVID category, but I'm just going to throw it in here as well. Things like post-exertional malaise. This is fatigue after exertion. This could be exercise, which is most commonly how it's referenced, but it could be things as simple as washing dishes. There's MIS-C, which is multi-system inflammatory syndrome in children. This is very severe. This is going to result in hospitalization immediately. And then death is another post-COVID complication. So why did I make that comment earlier about increased cumulative risk with more infections of COVID? Well, that's because that's exactly what we've seen. So here's 2 different studies of very large groups of people. So this first one here on the left, they're looking at 1 infection, 2 infection, and 3 and more infections. This was, I believe, back in 2022, if I'm not mistaken. So back then, there was not as many people that had lots of infections, but there were lots that had 1 and 2 infections. But we see very clear signals that you're going to have an increased risk of hospitalization, increased risk of cardiovascular disease, pulmonary disease, fatigue, kidney disease, and diabetes. The more COVID infections you have. So COVID, once you have it, is resulting in a cumulative damage that is going to be compounded every single infection you get. So this is why we should always, even if we've had COVID infections in the past, we should try to limit the amount of future COVID infections that we get so that we're not increasing our risk for major health issues. This is another more intensive study that looked at the same type of thing. I think this was a year later in 2023, but it confirms the exact same thing we saw for a gamut of complications, post-COVID complications. So we're looking at cardiovascular issues, coagulation and other blood issues, diabetes, fatigue, GI issues, kidney issues, mental health issues, musculoskeletal, neurologic, and pulmonary issues. And you see 1, 2, and 3 or more infections with the green, maroon or brown, and then the purple respectively. So these are all clearly increasing with the number of infections, which is putting an excess burden on our healthcare system over time. So these are post-COVID complications. So now let's move into the second side of infection-associated chronic conditions, long COVID. So long COVID initially was nicknamed long haulers by people that had it and were trying to figure out what they had, or long COVID because they're like, I had the COVID infection. It's lasting for a really long time. I'm still feel sick. I don't know what's happening. I'm having these new issues. And that's where the name long COVID came from, because they're like, I don't know, maybe I just haven't cleared the virus for a very long time. And then scientists were calling it PASC, post-acute sequelae of long COVID. So sequelae is just a fancy word to say things that happen, features of something. Essentially is what that is. So you're having, after a COVID infection, post-acute COVID, you're having these things that pop up is essentially what that fancy term is saying. So work groups have defined long COVID distinctly as new, persistent, or relapsing issues that occur 3 or more months after an infection. So it has to be sustained over a time. But again, these can be brand new issues that you never had before. Persistent issues, so something like you had asthma, but after your COVID infection, your asthma has gotten worse. So that's something like that. And then you could have relapsing issues. So like it's okay for a couple months, then it's bad for a couple months. It's okay for a couple months, it's bad for a couple months. That still qualifies as long COVID. So what is generally in these categories? You can have GI issues long-term. So this is like a new food allergy, like gluten sensitivity, like for me, but that was with norovirus. You can have chronic nausea. That's very common. Chronic diarrhea, again, very common after a COVID infection. Brain fog, so neurologic issues. So this can be concentration issues, memory recall, or impulse control issues. And then another thing that happens seemingly commonly enough that it's significant is dementia in younger middle-aged people. This is happening at a more frequent rate ever since the emergence of COVID. This was initially very rare, but we're seeing more and more younger middle-aged people developing dementia, and even some children in some cases. New onset diabetes, newer relapsing cancers, musculoskeletal issues. So a couple examples include polymyositis. This is like muscle weakness in your shoulders, hips, thighs, or neck. The most common is in your legs or hamstrings. Arthritis, also in kids. There's been several documented case studies where kids have actually developed arthritis in their hands and elbows as well. So those case studies are kind of crazy. Osteoporosis, particularly in older adults. We can have peripheral and central nervous system issues. So this could be generalized numbness, tingling, or pain throughout your entire body. POTS, postural orthostatic tachycardia syndrome. So just for like a very high level basic overview, when you go from like sitting to standing, your heart rate will spike a lot. Typically, I think that's considered 30 beats per minute higher than it was before. You're going to get dizzy, and among other things. MECFS, so myalgic encephalomyelitis. This means you're not going to have energy to do anything. Like everything literally tires you out. Like you can't get out of bed. You just have no energy for anything. And we see that this is not just like a one-off thing. So we've seen in multiple studies now, this is a consistent finding across many countries, across lots and lots of research, that with the number of infections increasing, your percentage chance of getting long COVID increases as well, which matches with the cumulative damage that we saw in the post-COVID complications section of this. So we're seeing one infection sitting around 15%, two infections around 25, three or more around 40%. In another study on different data, we're looking at once versus multiple. So we're increasing, so PASC, long COVID, non-PASC, not long COVID. These are the proportion of people. So we'll just look at the red. So if you just have one infection, it was having it about 15%. Same with the other study. When you have multiple infections, it's jumping up. So now we're at about 30% for multiple. In this study, depending on the severity of your infection, if you have mildly symptomatic, moderate, or severe, the incidence of long COVID goes up. And if you're unvaccinated, you have a higher likelihood of developing long COVID than if you're vaccinated. But again, the greater number of infections, the greater the chance of developing long COVID. So even if you're vaccinated and you have repeated vaccinations, the number of infections is really the important part because that's going to have cumulative damage on your body. And then just to really pin the donkey's tail here. So we have 1, 2, and 3 infections reported between 2020 and 2023. The cumulative risk of long COVID is going up with every single infection. So they had 14%, 23%, and 37%. And these are all different data sets. And we have high agreement between all of them, where we're having a massive jump in the proportion of people that contract COVID developing long COVID with each successive infection. So this is going to be problematic for us in the very near future when our entire population at all ages has become disabled, because it's important to note that while children were vibed out to not be affected by COVID as severely as adults, we're finding they have the same exact rates of long COVID as adults do. And they've certainly had more infections than us at this point because they're around a lot of other children, and children are gross and sick a lot. So they likely have more infections on average than adults do. And right now, I think it was recently released that long COVID is the number one chronic condition in children right now. So this is not good. And then the final phase is going to be viral persistence. So again, infection never cleared, you have viral pockets. So the way to say this is that the virus finds a happy little home within your body where it can camp out for the long haul and continue to replicate while evading your immune system. So this can generate cryptic lineages, old variants that have fallen out of active circulation and spread that seem to pop up with minimal or high number of mutations over long periods of time, show that this is a reality, that there is viral persistence of COVID in people. And in most long COVID patients that have been diagnosed, there is active signs of immune fatigue and T cell exhaustion, which would occur if your body is actively fighting a virus, COVID-19 in this case, for a very long period of time. So we're seeing signs in people's bodies that they're having long-term active battles with active infection. So this is confirming that as well. We know that viral rebound that occurs between long periods of time with the same or near identical variants in several case studies has proven that people don't always effectively clear all of the virus. And currently it's thought to linger in the intestines, most likely, as it began as an enteric virus. So this means it's a gut-focused virus in bats. So we've seen in chronic patients that COVID-19 gathers further mutations that align it with sarcoviruses. This is the word for bat coronaviruses. Specifically, this would be Pangolin bats. So this is showing that it's sort of like back mutating into bat coronaviruses in people's guts when it's having a long-term infection where it's found a happy little home in your body. And then since it's, again, a zoonotic spillover disease from Pangolin bats, there's a high potential for animal reservoirs to happen. So this is another form of viral persistence in neighboring animal communities. because COVID has proven that it can cross species. And then another sort of hidden part of viral persistence is persistence within the long-term frozen food supplies. So we know that COVID can survive being frozen for very long periods of time. So this would be essentially once the food was thawed, it would undergo reactivation following this period of preserved dormancy. And then after consumption of these goods with inadequate cooking or high preparation food handling and inappropriate cleanliness practices, it can then be reintroduced into circulation by infecting people. So these are all different types of viral persistence that can occur with COVID. And that concludes basically everything that can go into an active infection with COVID. I hope you've learned something. And this is why it's not so simple, that it's not just like you're sick and you're done with COVID. Lots of different things can happen. And it's important that we understand this to make better decisions about how to protect ourselves and others by wearing high quality N95 masks, by getting vaccinated, by advocating for appropriate air standards. So this would be high turnover rates of air within facilities, as in addition to adequate HEPA filtration, making sure that we keep the oxygen, the CO2 levels low within buildings under 620 parts per million. Among other different methods. So make sure you're advocating for everything. Yeah, that's all. Have a great day. Hope you learned something.